Thanks very much. My name is Shelley Fuller. I work for DWP and I'm part of the Work and Health Unit. At the table discussion today, we were discussing the national and local ambitions and the intentions associated with the Green Paper on Improving Lives, the Health, Work and Disability Green Paper. We had three main points that we came up with, three sort of key positions that individuals would like to feed back. The first one was one of the top issues is the need to integrate the key partners in the agenda, and the challenge there is identifying who those partners are. And the key thing that people were asking for was that we would from a national or regional level to actually help individuals identify who those partners were and actually set some direction. So rather than just leaving it to partners to talk about health and work, it was about actually saying they should be talking about health and work and giving them that sort of strategic direction to then help them to collaborate more greatly. And one of the other things that came up in relation to collaboration was the importance of data sharing. Data sharing is the new health and safety. Individuals were concerned about data sharing, but should they be as concerned as they are? And what are the opportunities for data sharing that exist already? The second point was about building a shared definition and understanding of what success looked like, what the outcome was that was wanted by those local partners. Having a shared outcome would enable individual areas to understand that this was what the West of England, for example, wanted as an outcome, rather than everybody having individual outcomes. And finally, there was a lot of discussion at our table about developing a shared language. There was a lot of talk about the social model of disability and building everything around that social model of disability and being inclusive and not divisive, not having a them and us culture, empowering the individual to enable them to set goals and to help them to achieve a work outcome in relation to their health. And that was it. Thank you.
Hi, I'm Paul Scott, Deputy Director of Public Health in Bath North East Somerset Council. So the table that we were discussing today was partnerships. That's looking at different organisations working together across the West of England area. So one of the things we talked about was that there are lots of different organisations both working on the ground and working strategically, and there needs to be better join up. There needs to be better and simpler working. So we need to make it very easy for people, employers, people using services, to have single points of help and support. So that was one of our priorities. The second was that we need to think more clearly about the outcomes we want to achieve. So that's so that all these different organisations from health, employment and so on can all be talking about the same kinds of things and understand each other better. It's complicated, so we need to make it really clear and simple for people. And the third was about involving people using the services more. Sometimes we get a little bit caught up in our own organisations, and we need to think more clearly about involving people either looking for work, employers and so on, just really involving them in everything we're doing. So those were the three priorities for us.
Okay. Yeah. Hi, I'm Ian Popperwell, Commissioning Manager for Mental Health in the Bristol Clinical Commissioning Group. I led the discussion on the table about mental health and employment, and we've got three issues that emerged. The first is the tension between well-being and performance. On the one hand, the expectation for people to perform to a high standard, to be present, to be well at all times, and talking about that being difficult. And on the other, the need for whole employer workplace well-being, where mental health for everybody can be talkable about, rather than just the problematic mental health of a few. So this works in relation to awareness training. The medical approach would say that you make people aware of diagnoses and mental health conditions. The well-being approach would say you make people aware of what makes for good well-being for the whole workforce. And if it's talkable about by everyone, then people's difficult mental health issues can be seen as part of the normal whole. This approach also, we talked about would lead on to good flexibility in workforces, because an employer would want to hold on to their staff, would want staff that represent a wide range of experience and who need flexibility. Everyone needs flexibility at different times, not least people who have some kinds of mental health issues at different times. So we're very much taking a well-being approach to that. We'd want to see the needs around mental health adjustments to be seen as straightforward as those for someone who uses a wheelchair, where an employer might put a ramp in or think they need to change the level of a desk. Employers are perhaps less aware of the adjustments they need to make around mental health. We'd want to see those things normalised. The second thing was around people with mental health issues people who are unemployed, whose mental health gets worse through unemployment. So it might be that someone's been made redundant, or they're off sick for some other issue, and their mental health gets worse in unemployment. So there's people who aren't in services. And we were thinking how important social networks are, normal social networks, not special ones just for disabled people, but normal social networks and activity and overt services that help people back into work and support them in employment. And the last thing we talked about was the issue of low expectations, particularly in services, mental health services and other ones, where employment is seen as a goal, a distant goal, that's the end of this whole serial process of recovery, therapy, work experience, volunteering, and only at the end of which can someone even think about working. And we want to challenge that and to see employment as being concurrent with other things that help improve their skills and their confidence and their mental well-being. Not to make employment a distant goal, to make it a current one, and to look at the kind of interventions that support that, and therefore increasing people's expectations.
I'm Marion Steiner. I'm a GP in North Bristol, and I'm the Bristol CCG Self-Care and Social Prescribing Lead. We were discussing the role of fit notes in our group and the way that the system can nurture people to get back to work. We came up with some top priorities, one of which was a mapping exercise across the west of England to look at what resources there are in existence at the moment for employers and for employees, and also for doctors, both in primary care and the secondary care system, to help people to get back to work. There seems to be a yawning gap there in terms of information. The second priority was establishing a resource which would probably draw on a number of different resources but brought together in one place. That could be used by employers who are seeking to retain or recruit employees, and also used by doctors and people in healthcare, wider healthcare professionals, to help people who have a long-term condition diagnosis or a disability, or are facing dismissal or a need to return to work, but no one's quite sure how to do a phased return, particularly in terms of mental health problems. What does a phased return to work mean? And then an overall education process, and we talked about the fact that there may be an ignorance amongst employers of the benefits of retaining staff, of maintaining a healthy environment at work, and improved communication between health professionals and employers, and Job Centre Plus, a combined resource for all of those, but also an education drive for clinicians in primary and secondary care, in medical school training, nurse training, all of those areas. Also amongst the population, the value of work to health. So a general upskilling of knowledge in this area.
Hello, I'm Vicky Morris. I'm the Chief Executive of the Care Forum, and I facilitated one of the workshops here at the conference. Our 3 key points were firstly to do with hubs and job centres, and whether we need job centres or whether we need more multidisciplinary hubs where people can access a range of information and advice in order to make a more holistic plan about the next steps that they need to take. The second was very much about the focus on well-being throughout life and thinking that that is a journey that people move through, and that work should be seen as a health outcome, and really encouraging people who are working with people who are suffering ill health to think about work being good for well-being and good for health, and therefore an outcome that is relevant to their performance. And then thirdly, we were talking about the quality advice that's available to people when they're making decisions, maybe about coming off benefits or moving into employment. Really, it's terribly important that people have access to good quality, consistent advice so that they can make informed choices about what they do next.
Okay, so my name's Sue Moss. I work for Bristol City Council in public health, and I lead for public health on social prescribing. In our group, our top 3 priorities around social prescribing and getting people back into work was something about, the first one was about the social prescribing not being a fully understood concept, and we need to raise understanding with professionals about what social prescribing is and how it can be part of the journey for somebody back into work. Our second point was that social prescribing is quite often a stepping stone for getting somebody back into work. So people will come along and be referred by their GP maybe to a social prescriber who will encourage them to get involved with a group maybe. From going along to a group of some sort, they may well start volunteering, and from volunteering they may end up going back into work. And therefore it is a stepping stone to work. However, that's something that's quite difficult to measure, because quite often the social prescribing service will no longer be involved with the person by the time they're back into work. So there's something there about we recognise that it's an outcome of, it couldn't be well be a long-term outcome of social prescribing. However, how do we measure it? And we need to think about that. And the third point was about placing a greater value on volunteering and on people's lived experience as well, and how valuable that is. And volunteering quite often is something that people get involved in as a result of social prescribing. They get involved in the community and become volunteers, and there's something about how do we place a greater value on volunteering and recognise that its importance in way back to work. So there's the 3 points from the social prescribing group.
Okay, my name is Leo Capella. I'm a campaign project coordinator for I Can Make It at Disability Rights UK. The table we were on, table 5, identified a number of key issues and problems affecting disabled people getting jobs and in Bristol and the wider area. The key one was the fear from employers of employing people with disabilities, particularly deaf people and visually impaired ones, especially down to ignorance. There's also fear on the other side with disabled people, particularly those who are claiming ESA, feeling that worried about coming off ESA, particularly in those first 2 to 4 weeks. Second, we didn't feel particularly qualified to answer the second question around commissioning and delivery networks, given that most of all of our table was in some way in the third sector. But we did comment and make a number of comments. For instance, he thought of, just trying to find. For instance, the last only deals with the commissioner to ensure the future of their service, and we felt that there was a lack of understanding from some commissioners, although it has to be said there are some good people in the system, and that they're influenced by targets rather than understanding at the ground local level. So our three priorities were, top three priorities, there were several more, but we thought that universal design in new builds and focusing on enabling people with disabilities, giving a good environment would help. We also thought that this should influence working at a grassroots, bottom-up approach and making access to work easier to access on a national level, increase funding and make it less scary for employers. This triangle of priorities, excuse my curved attempt at a triangle, should reduce the fear factor along with our other points on our paper. Thank you for viewing this.
Hi, I'm Nick Smith. I'm the Bristol City Council Strategic Intelligence and JSNA Manager, and I was describing on the data table. In terms of the three priorities, in brief, there were the three priorities that we came up with for further action were: one, to use a consistent data set; secondly, to address the skills gap; and thirdly, to look at further data on the barriers to addressing parity for underrepresented groups in the labour market. So I'll just go through those in a little bit more detail. For the first one, using a consistent data set, this was for all organisations over time to start using a consistent set of indicators to address the issues, so as to improve partnership work. A possible source of doing that would be the JSNA, the Joint Student Needs Assessment, which each local authority area has to do, bringing those more into line with each other, or other routes could be available as well. The second point, the skills gap, this was to understanding better the output to the local education system, yes, across all levels, of which we know there is a lot of data on these outputs, but then to cross-reference this with how to better align that with local needs. What do employers across the West of England area tell us they need? Obviously we know it's different in each area, but how much data, how much level of detail rather, can we drill down into to be able to then balance that skills gap and see what practical steps would be needed to make sure that people coming into the employment market have got the right skills that employers are telling us they need. And the third point is the barriers to achieving parity. Overall, that's about having more targeted support for people going into work so that we can address the issues, the barriers that are stopping certain people from underrepresented groups, obviously disabled people being the one that we particularly looked at today. Also other groups, whether it's through equality groups or other splits, and just geographic, socio-economic groups, to understand what are the barriers that are stopping them from joining the labour market with the right skill sets in order to, as we said, to achieve parity there. There's also looking at, in more detail, at benefit data, claimant data, looking at economically inactive people, and being able to split that, not just by the equality group and the geographic area, but also by the reasons as to why some of these groups were economically inactive, and what then can be done to support them to move back into employment. Thanks.
Hi, I'm Jane Taylor, and I work for Bristol City Council, Head of Service for Employment Skills and Learning, and I'm also sharing a project officer role with the new Combined Authority for Devolution. On my table, we were considering issues in relation to in-work programs. It was a really good discussion. I had quite a number of people got involved, and we whittled it down to three main priorities. The first was we considered all of the current forums at a strategic level where commissioning and decision making across health and employment comes together, and we felt the current forums don't quite fit the bill, and therefore we like the idea of the establishment of an integration board which would bring employment and health commissioners and decision makers together. And we thought that that integration board could oversee, as a first piece of work, a work and health hit in the west of England in order to give us that baseline of kind of the key issues and the key data. And that would inform our work programme. So that was the first one. The second one related to support for employers. And the feeling in the group was that many employers, whilst they are very committed, they sometimes feel unconfident in relation to employing disabled people and people with health conditions. They don't always know about access to work and how to meet access needs confidently. And it's how do we provide some quite practical support? And that was something that we felt has got to be given a bit more consideration. And thirdly, was how do we also support health practitioners in GPs, in also people working at a community pharmacy level, as well as public health, people working out in communities. And it was felt that on the one hand, it would be really great to see a really good framework and availability of social prescribing across the board. But in addition to that, it's not just about simple referrals to a clear menu of employment support services for people working in health. It was also felt that some support for health practitioners in relation to the advice that they can give patients in relation to employment-related issues would be positive too. So, for example, that may be a patient in relation to kind of struggles they may have, when to disclose information to an employer. Really great if actually, rather than referring, that advice could be given on the spot. So again, what's the best way we can share some of that through training and through maybe online tools? So those were our three priorities.